Hello everyone. Today we will discuss about urinary tract infection in infants and young children under the 5-mark short note series. Urinary tract infection is a bacterial infection of the urinary tract, that is urethra, bladder, ureter and kidney. It is quite common in infants and children and may indicate any urinary tract anomaly also. Early diagnosis prevents renal scarring and chronic kidney disease. So what is the mode of transmission? Most infections are ascending from urethra to bladder to kidneys. Hematogenous spread occurs in neonates with sepsis. Fecal flora contaminate perineum and ascend. Usually E. coli will be the suspect. It is facilitated by poor hygiene, diaper use and urinary stasis. It is more common in male infants due to structural defects. After 1 year, it is higher in females due to the shorter urethra. Recurrence occurs in roughly 30% cases within 1 year. Early detection prevents hypertension and CKD in the long run. What are the causative organisms? E. coli is the most common organism causing 80 to 90% of the cases, followed by Klebsiella, Proteus, Pseudomonas, and Enterobacter. In case of gram-positive organism, Enterococcus faecalis, Staphylococcus saprophyticus are more common, and this is more common in adolescent girls. Coming to the risk factors. In case of infants, congenital anomalies are the most common risk factors like posterior urethral valves or vesicular-urethral reflex, uncircumcised males, prematurity and low birth weight, dehydration and poor feeding, incomplete bladder emptying or neurogenic bladder. In case of children under 5 years of age, female sex because of shorter urethra is a risk factor, constipation and urinary retention, poor perineal hygiene and tight clothing, bubble baths and chemical irritants can also be a risk factor, and instrumentations or catheterization are specific risk factors. Generally, diabetes mellitus, renal calculi, or any immunodeficiency disorders or any anatomical obstruction can also be risk factors in the category of infants, children under the age of 5 years. Coming to the classification, it is classified into upper urinary tract infection and lower urinary tract infection. If it happens at the level of bladder or urethra, we consider it as lower urinary tract infection, whereas if it is a bladder infection, we call it as cystitis, urethral infection, we call it as urethritis. In kidneys, we call it as pyelonephritis, and in ureter, we call it as ureteritis. So, lower urinary tract infection happens at the level of bladder or urethra. Symptoms will be frequency, urgency, dysuria, suprapubic pain, cloudy or foul smelling urine. Usually, systemic signs are absent. Whereas in case of upper urinary tract infection, site will be in kidney or renal pelvis. There will be high grade fever, flank or loin pain will be there, chills, vomiting and malaise will be there. Systemic signs like toxic look, leukocytosis and raised CRP will also be there. Coming to the clinical features. In infants less than 1 year, fever will be there without any focus, poor feeding, vomiting, irritability, prolonged jaundice, failure to thrive, and foul smelling urine. Between the age of 1 to 3 years, there will be fever, abdominal pain, frequency will be increased, crying during urination will be there, and there will be refusal for food. In case of preschool as well as school aged children, there will be dysuria, increased frequency, urgency, suprapubic pain, flank pain, hematuria, and enuresis, that is bedwetting, will be common. The clinical approach will be first we have to suspect UTI in any child with any unexplained fever. Then collect the urine sample appropriately. If the child is less than 1 year, suprapubic aspiration is the preferred mode. 1 to 2 years catheter sample and greater than 2 years clean catch midstream will be the preferred choice. And then perform urine routine, culture and relevant blood test. Imaging is indicated like USG, MCU, DMSA as per the symptoms. Coming to the investigations, urine microscopy, if the pus cells show greater than 5 cells per high power field, and in case of culture greater than or equal to 10 to the power of 5 CFU per ml, a single organism confirms the diagnosis. Usually it will be E. coli. Blood tests like CBC, CRP and renal function test are indicated as per the symptoms. Ultrasound, KUB, MCU for reflex and DMSA for renal scarring are indicated. Pharmacological treatment. If it is infant less than 2 months of age, cefatoxime 50 mg per kg 8 hourly or ceftriaxone 50 mg per kg per day for 7 to 10 days IV. Children greater than 2 months, in case of mild, there will be suggested drug is amoxicillin clavulanate 20 mg per kg in 3 divided doses or cefixime 8 mg per kg in 2 divided doses for 7 to 10 days oral. And in case of recurrent or resistant infection, nitrofurantoin 5 to 7 mg per kg in 2 doses for a week. Oral is indicated, but it is not indicated in case of pyelonephritis. colitis. Coming to the supportive care, includes fluids, paracetamol, and treatment of constipation. Then the child is indicated for hospitalization. If the age is less than 2 to 3 months, vomiting or any dehydration is there associated with toxic or septic appearance, with a high fever associated with renal involvement, failed oral therapy or renal impairment, and structural anomalies are present in imaging. Prognosis: with early diagnosis and treatment, prognosis is excellent. Delayed or recurrent infection may cause renal scarring. Complications include hypertension, CKD due to reflex nephropathy. Follow-up and imaging are essential. Coming to the prevention, encouraging adequate intake of fluids and frequent voiding, maintaining perineal hygiene, and avoid tight clothing and bubble baths. Circumcision reduce the recurrence in boys, and cotrimoxazole 1 to 2 mg per kg at a bedtime for reflex cases is indicated. So, coming to the summary, E. coli is the most common UTI causing pathogen. Always suspect UTI in febrile infants without focus. Proper urinary sample collection is vital. Early treatment prevents renal scarring and CKD. Hospitalize young or toxic children for IV therapy and monitoring. Hope you have learned through this video. Thank you.